Hello, my name is Naval Davar. I'm a faculty in the Department of Leukemia at MD Anderson Cancer Center in Houston, Texas. And today I'll be talking about the burden of disease in patients with myelofibrosis. How sick are you from the disease? So as a background, I think it's very important to note that there are updated criteria in 2016 by the WHO for diagnosis of myelofibrosis. And the criteria focus on the pathology of the disease, which includes bone marrow changes, including atypical proliferation, increased fibrosis on reticular trichrome stain, as well as molecular mutations that have now become, I think, the pillar of diagnosis for patients with myelofibrosis. These include JAK2, calreticulin, MPL, as well as the absence of molecular mutations such as BCR-ABL, which would phenotype a patient as CML, which has a different outcome and different treatment. Minor criteria have also been included, and these look more at what I would consider the burden of disease factors or the symptom burden for myelofibrosis. And these include anemia, which of course can cause fatigue, shortness of breath, dizziness, headache, chest pain, leukocytosis, which when it gets severe above 50, 60, especially with the high predominance of myelocyte, monocyte, can also cause blurring of vision, headache, dizziness, chest pain, kidney problems, as well as palpable splenomegaly, which has been the center point of evaluation as well as outcomes to treatment in patients with myelofibrosis with JAK inhibitors, and is usually correlates very closely with the overall symptom burden and cytokine levels, and then other things such as LDH and leukoerythroblastosis. Now looking more at what are the outcomes that we expect with the good treatment of myelofibrosis. So I think there are 3 or 4 main pillars. One is reducing splenomegaly, which usually has a very close correlation with the symptom burden, including local symptoms such as abdominal pain, distension, early satiety, weight loss, but also correlates well with general symptomatology because when the spleen is big, usually we know the disease is active, cytokine levels are high. The next one is addressing cytopenias, and I think a lot of times we focus heavily on the spleen and the cytokine-related symptoms, but there's about 20-25% group who has not a big spleen, maybe not as high levels of cytokines, but has significant cytopenia, especially anemia, and their symptoms are a little bit different. They're anemia-related, such as fatigue, shortness of breath, lethargy, apathy, depression, and so these have to be addressed a little bit different. And then constitutional symptoms, which, as I said, can come either from big spleen related or from cytopenia related or combination or from the cytokines themselves. So here we look at a slide that looked recently at a study, landmark analysis published by Ruben Mesa and his group, looking at different groups of myeloproliferative diseases, MF, PV, ET. The upper part, which is the dark blue lines, basically shows that even in patients who have, by traditional scoring, including cytogenetic, white count, hemoglobin, spleen, such as the IPSS or DIPSS score, low-risk patients still have a significant symptom burden, significant quality of life. In fact, when they coded low-risk patients by IPSS, almost all patients had 1 to 2 days of loss of work or calling in sick, showing that this disease was impacting not only the patient's well-being, but also the greater socioeconomic outcome and impact of this disease. Here we outline the results of the approved agent, the only approved agent for myelofibrosis, which is a JAK inhibitor, ruxolitinib. Also to note, there are a number of JAK inhibitors in development, but the one that is approved is ruxolitinib. This was based on 2 large phase 3 studies, Comfort 1 and 2, both showing a very significant reduction in spleen between 30 and 40% at the predefined endpoint of 24-48 weeks. Although many patients, more than 90%, ended up having a spleen reduction if you looked at it as a continuous follow-up. Also now there's data emerging showing that the symptom score came down very nicely in these patients who had a spleen reduction. Almost unanimously, all patients had an improvement in symptoms between 12 to 16 weeks. Here's the data I was mentioning showing that in the patients who have good spleen reduction, they had almost the equivalent improvement in symptom. As you can see, those who had greater than 35% reduction had a very significant reduction of the symptom score. Similarly, those who had a greater than 35% reduction in spleen on the right side have a very good improvement in their global quality of life, which is assessed by a standardized criteria that has now been used in hundreds of patients. Also important to note that the early treatment is quite important. So here you see patients who are on the placebo arm of the Comfort 1 study, so the ones who did not get the JAK inhibitor. And you can see that even within 24 weeks, their spleen size as well as symptom score continue to go up almost up to 30 to 40% median increase just within 24 weeks, showing that in these patients who have big spleen, who have significant symptoms, early intervention is quite critical. And here we look at the data that was published very recently by Dr. Harrison and their group, showing that with the JAK inhibitors, 97% of the patients have a reduction in spleen. Of those, about 60% have a 50% or more reduction in spleen, which is considered to be very significant and usually correlates closely with the symptom reduction as well as survival benefit. These results were mirrored in the COMFORT-1 study that has also been presented, but we will not discuss that in detail at this time, although the publication is online. So in conclusion, we see that most patients with myelofibrosis, including those who have low risk by IPSS or DIPSS, may have a significant symptom burden, and symptom burden has not been closely included in the IPSS and DIPSS at this time. Very importantly, reduction in spleen volume is our best predictive marker for improvement in survival, but also correlates closely with reduction in symptom burden. 97% of patients have some degree of reduction in spleen volume, which usually correlates with improvement in quality of life, symptom burden. And delay in therapy is usually associated with progressive increase in both spleen size and symptoms, indicating that early intervention should be done in patients who require it. Thank you very much for listening.